Hi everyone, this is a voiceover lecture on newborn adaptation. And so in this newborn adaptation lecture, we'll cover some of the physiological changes that has to take place as the newborn is delivered. First of all, what is the newborn? Well, the period of newborn includes the time of birth through the 28th day of life. During this period, the newborn adjusts from intrauterine to extrauterine life. It is very vital to know a newborn's normal physiologic and behavioral adaptation in order to recognize alterations from normal. So to begin life as a separate being, the newborn must immediately establish respiratory gas exchange in conjunction with marked circulatory changes, and this is called the neonatal transition. All other newborn systems change their level of functioning and become established over a longer period of time during the neonatal period. And so we'll start with initiation of respiration in the newborn. During the latter half of gestation, the fetal lungs continuously produce fluid. This fluid expands the lungs almost completely, filling the air spaces. Some lung fluid moves up into the trachea and into the amniotic fluid and is then swallowed by the fetus. However, production of lung fluid diminishes 2 to 4 days before labor. So approximately 80 to 100 ml of fluid remains in the respiratory passageway of a normal full-term newborn. The newborn's ability to breathe air immediately when exposed to the extrauterine environment appears to be the consequence of weeks of intrauterine practice. Hence, breathing can be seen as a continuation of an intrauterine process. The lungs convert from a fluid-filled to a gas-filled organ. Fetal breathing movements occur as early as 11 weeks gestation. And so in order to maintain life, the lungs must function immediately after birth. To do this, two radical changes must take place. First, pulmonary ventilation must be established through lung expansion following birth. Second, a marked increase in the pulmonary circulation must take place. So these are the major things that have to take place in order for the baby to immediately maintain life after delivery. These are the two radical changes that must take place. Pulmonary ventilation must be established through the expansion of the lungs, and a marked increase in the pulmonary circulation must take place. Now let's talk about some of the causes of respiration. There are 4 major causes of newborn respirations, and they are nicely outlined here in the PowerPoint: chemical, mechanical, thermal, and sensory. At birth, the newborn's first breath starts the serial opening of the alveoli. The remaining fluid must be removed from the newborn's lungs to permit adequate movement of air. An important chemical stimulator that contributes to the onset of breathing is transitory asphyxia of the fetus or the newborn. And so we have the first one there, chemical. So chemical or the chemoreceptors in the carotid arteries and the aorta respond to changes in the blood chemistry. So what happens is that we have a state of hypoxia, which is normal at birth. So at birth, we have this transient hypoxia that happens. And so this state of hypoxia happens with the cessation of placental gas exchange when the cord is clamped. So after the baby is delivered, the cord is clamped. So this will trigger that hypoxia, which is very normal, and this is with cessation of placental gas exchange when the cord is clamped. Then a decrease in PO2 and the pH of blood and an increase in the pCO2 in the blood will cause the chemoreceptors to send a signal to the medulla to take a breath. So that is what the chemical cause of respiration is. Although this brief asphyxia is a significant stimulator, Prolonged hypoxia will, however, cause central nervous system depression. So we don't want this intermittent or this transient hypoxia to be prolonged, because prolonged hypoxia will cause central nervous system depression, and this is absolutely abnormal. The primary mechanical events that initiate respiration involve the removal of fluid from the lungs as the fetus passes through the birth canal. And so that leads us to the second cause of respiration, which is mechanical. During a vaginal birth, the fetal chest is compressed by the narrow birth canal, and about 1/3 of the fetal lung fluid is squeezed out of the lungs and into the upper airway passages, into the mouth or nose, and suctioned out. So as this baby that is delivered vaginally is coming out through the narrow vaginal canal, that vaginal canal causes the fetal chest to be squeezed or to be compressed. And that helps to remove at least about 1/3 of the fetal lung fluid when the baby is coming out through that narrow vaginal canal. So when the chest is allowed to recoil, a tiny bit of air enters into the lungs, which helps remove the viscous fluid. In a normal newborn, lung fluid moves rapidly into the interstitial tissue, but may take several hours to move into the lymph and blood vessels. So about 80% of the fluid is reabsorbed within 24 hours of life, within 2 hours of life, I should say, and completely absorbed within 12 to 24 hours after life. The third one is thermal cause of respiration. At birth, the infant moves from a warm fluid-filled environment to a much cooler temperature. The baby has sensors on the skin that responds to this sudden change in temperature by sending signal to the brain that stimulate the infant to breathe. However, excessive cooling may cause profound depression and evidence of cold stress. This is why it's very important to prevent heat loss in newborns immediately after birth. And the last cause of respiration is sensory. Every sense around the infant may initiate respirations. They include the tactile, auditory, and visual stimuli at birth. During intrauterine life, the fetus is in a dark, sound-dampened, fluid-filled environment. So what happens is that after birth, the newborn experiences lights, sounds, and the effects of gravity for the very first time. Thoroughly drying the newborn and placing the newborn in a skin-to-skin contact with the mom provides ample stimulation and decreases heat loss. The cardiovascular adaptation. The onset of respiration stimulates cardiovascular changes that are necessary for successful transition to extrauterine life. Marked cardiovascular system changes occur at birth. So as air enters the lungs, PO2 rises in the alveoli, relaxing the pulmonary arteries and triggering a decrease in pulmonary vascular resistance. So as pulmonary vascular resistance decreases, the vascular flow in the lungs increases to 100% 24 hours after birth. Other changes include the foramen ovale and the ductus arteriosus. So these are other changes that will happen after the birth of this baby. So what is the foramen ovale? Well, the foramen ovale allows blood to enter the left atrium from the right atrium. This is called the right to left shunting, and this allows the blood returning to the right side of the heart to bypass the fetus's fluid-filled lungs. Remember, we said earlier that in utero, the fetal lungs is fluid-filled. So the job of this foramen ovale is to allow blood to enter the left atrium from the right atrium, and this is known as the right to left shunting. It allows the blood returning to the right side of the heart to bypass the fetus's fluid-filled lungs. And so what happens after birth is that after birth, the foramen ovale closes 1 to 2 hours after birth, followed by the ductus arteriosus slowly closing within 15 hours after birth and allows complete vascular flow to the lungs. So if these two are still open after birth, if they are still open after the delivery of this baby, the newborn is considered to be poorly perfused. Now let's talk about the PDA, the patent ductus arteriosus. Well, the ductus arteriosus connects the pulmonary artery with the aorta because of increased left atrial pressure. Because of increased left atrial pressure, and also the fact that the ductus is sensitive to increased oxygen level and body chemicals, it will now begins to constrict. If the lungs fail to expand or if PO2 level drops, the ductus remains patent. I will repeat, if the lungs fail to expand or if PO2 level drops, the ductus remains patent. However, fibrosis of the ductus arteriosus occurs within 3 weeks after birth, whereas the functional closure happens within 15 hours of life. So within 15 hours of life, you will expect to see a functional closure of the ductus arteriosus. The thermal stimuli. Significant decrease in environmental temperature after birth helps the newborn to begin breathing. The cold stimulates skin nerve endings and the newborn responds with rhythmic respiration. Cold stress is excessive heat loss that requires a newborn to use compensatory mechanisms such as increased respirations to maintain core body temperature. During cold stress, oxygen requirement increases, glucose use increases, the acids are released into the bloodstream and surfactant production decreases. The effect of cold stress can indeed be devastating and fatal to newborn. The most at risk for this cold stress are preterm babies, or babies who have what is called IUGR. So IUGR or growth restricted babies and those with asphyxia and respiratory difficulties. So these are the ones that are at risk for developing cold stress. It includes preterm babies, IUGR babies, babies with asphyxia and respiratory difficulties. Both preterm and small for gestational newborns are at risk for cold stress because they have decreased adipose tissue and also they have decreased brown fat storage or stores and glycogen available for metabolism. So these things are decreased and that is the reason why they are at risk for cold stress. So what will be the signs and symptoms of cold stress? Well, the signs include increased movement, increased respirations, decreased skin temperature. So you have a baby that is temperature is decreased, the baby that is hypothermic, decreased peripheral perfusion, hypoglycemia. So the baby's blood glucose level would drop. And what we consider as hypoglycemia in newborn is a blood sugar or blood glucose level that is less than 45 milligram per deciliter. So when you have a baby whose blood glucose is less than 45 milligram per deciliter, you will start to see manifestations of hypoglycemia such as tremors, irritability, apnea, jitteriness. So when a baby is jittering too much, tremors, those are classical signs and symptoms of hypoglycemia in a newborn. Sensory stimuli. Well, this has to do with the intrauterine life and extrauterine life. In intrauterine life, as we mentioned at the onset, we said that the baby was in a fluid-filled environment, in a dark, sound-dampened, fluid-filled environment, weightless, and now the baby comes out after delivery. The baby is now in the extrauterine life. The baby will see light for the first time, sounds, effects of gravity, and also the baby will get to experience abundance of tactile, auditory, and visual stimuli at birth. Thermogenesis. Thermogenesis is the process of heat production. There is non-shivering thermogenesis, and this non-shivering thermogenesis occurs when skin receptors perceive a drop in environmental temperature, and this non-shivering thermogenesis uses stores of brown fat or brown fat tissues to provide heat to newborn. And so the primary source of heat in hypothermic newborn is brown fat. Brown fat is the primary source of heat in hypothermic newborn. And this brown fat, which makes up about 5% of the body mass, is located on the mid-scapular area, the back, along the upper half of the spine, and towards the shoulders of a newborn. So brown fat is a primary source of heat in hypothermic newborn. Now let's talk about the methods of heat loss. There are 4 major types of heat loss. The methods of heat loss, and they're all listed here on the slide: evaporation, convection, radiation, and conduction. When you take a look at these images here, you see the babies. Each of them represents the method of heat loss. The first one is convection, radiation, evaporation, and conduction. So we'll begin with the first one, evaporation. Evaporation is the loss of heat that is incurred when water is converted to a vapor. And this evaporation is the most common type of heat loss. So the most common type of heat loss is heat loss via evaporation. When wet surfaces are exposed to the air, evaporation occurs. Heat is lost when the surface dries. At birth, the neonate is wet with amniotic fluid. So when the baby is delivered, the baby just came out from a fluid-filled environment. The baby is wet from the amniotic fluid. As the amniotic fluid dries up on the infant's skin, evaporation takes place. So the infant loses heat via evaporation. The same occurs in bathing an infant. So when you bathing an infant, you get the baby all wet. So if the water dries up on the baby's skin, that baby will lose heat via evaporation. So what are some of the ways that you as a nurse can prevent heat loss via evaporation? Well, the first one is to ensure that the newborn is thoroughly dried up after delivery. So drying the infant as quickly as possible after birth is a key to prevent heat loss via evaporation. And the second means is drying the infant immediately after bathing. So if you give a baby a bath, dry the baby up immediately so that the baby doesn't lose heat via evaporation. The second way of heat loss is convection, and that is loss of heat from the warm body surface to the cooler air currents. So when heat is transferred to the air surrounding the infant, heat loss by convection takes place. So if an air conditioner is kept on, or people keep moving around near the infant, you have that back and forth movement of people, increased loss of heat will happen. So what are some of the ways to prevent heat loss via convection? Well, the key ways to prevent heat loss via convection includes keeping the newborn out of drafts. So you don't place the baby's bassinet near a window or a door. So anywhere that draft can come in, cold air can come in, don't keep the baby there. Keep the newborn out of the draft, away from there. The second one, maintaining warm environmental temperature. So the baby needs to be kept in a warm environmental temperature. If it's too cold, the baby will lose heat. Keeping a preterm neonate in an incubator. When we have a preemie baby, we put them in an incubator. By keeping them in an incubator, we are preventing heat loss via convection. And the third one is heat loss via radiation. So radiation heat loss happens, or losses via radiation occurs when heat transfers from the heated body surface to cooler surfaces and objects not in direct contact with the body. So what do we mean by that? For instance, if you place cold objects, such as ice for blood gases, near the infant in the warmer, this will increase radiant losses. And so when infants are placed near cold windows or walls, heat will be lost by radiation. So how do you prevent heat loss via radiation? Well, incubators must have double walls. So you have to ensure that incubators have double walls. Cribs and incubators should be placed away from the walls and windows. So you want to keep the cribs and incubators away from walls and windows. And the last way to prevent heat loss via radiation is ensuring that liners must be dry inside cribs and isolate. So if you have liners that you use to line up the isolate or the crib, it must be dry, because if it is wet, it will cause that heat loss. It will cause the transfer of heated body surface to cooler surface, and that will be a result of heat loss via radiation. The final one is heat loss via conduction, and that is the loss of heat to a cooler surface by direct skin contact. So in radiation, it is an indirect. You have a cold substance that is indirectly causing heat loss from this baby, or causing heat loss to happen. So that is an indirect contact. An object that is that is not in direct contact. So that object is indirectly causing heat loss to happen. In conduction, this object is in direct contact with the baby. It is directly in contact with the baby. So the loss of heat to a cooler surface by direct skin contact will lead to the loss of heat via conduction. So when a neonate comes in direct contact with an object cooler than their skin, heat loss by conduction occurs. What do we mean by this? Well, chilled hands. If you walked out from the street in a cold winter day and you walk into the hospital, or you got home and you pick up your baby with chilled hands, that chilled hands is coming in contact, in direct contact with the baby, and that will cause the baby to lose heat via conduction. Cool scales. If you're weighing the baby with a scale that is cold, those cool scales, cold exam tables, cold stethoscopes, all those things can cause loss of heat by conduction, because they are touching the baby's body directly. You're touching the baby with a cold stethoscope. The cold exam table, you're placing the baby against a cold exam table. The baby will lose heat via conduction. So ways to prevent heat loss via conduction includes 1. Warming the objects that will touch an infant. So before you touch the baby, if you walked in from the cold air or the cold environment, warm your hands. Don't pick up the baby with a cold hand. Don't auscultate the baby's lungs or the baby's, listen to the heart with a cold stethoscope. Warm it up first. So warming the objects that will touch an infant is the key to preventing heat loss via conduction. Don't place a baby on a cold exam table. Placing an infant against the mother's skin helps prevent conductive heat loss. So when you put the baby on skin to skin, you are promoting or you are preventing heat loss via conduction. So remember these ways of preventing heat loss. Remember that evaporation is the most common type of heat loss. Remember that in evaporation, you want to prevent heat loss via evaporation by drying the infant as quickly as possible after birth, drying the infant immediately after bathing. With convection, you want to keep the infant out of draft. You want to maintain environmental temperature, keeping a preterm neonate in an incubator. With radiation, you want to make sure that the cribs and incubators are placed away from cold walls or windows. You want to make sure that the liners of the isolate or the cribs are thoroughly dry. Incubators must have double walls as well, and these are ways to prevent heat loss via radiation. And we talked about conduction. You want to warm the objects that will touch the baby. Placing the baby against mom's skin to skin is very ideal in preventing heat loss via conduction. Conjugation of bilirubin. Well, this term basically refers to the conversion of yellow lipid soluble pigment into water soluble pigment. Bilirubin is a yellowish breakdown product of the heme. It is a part of the hemoglobin molecule that is in the red blood cells. And so naturally, this bilirubin is thrown out of our body by means of a bile or urine. In utero, fetal unconjugated bilirubin crosses the placenta to be excreted, so the fetus doesn't need to conjugate bilirubin. However, after birth, the newborn's liver must now begin to conjugate bilirubin by itself, and this produces a rise in serum bilirubin levels in the first few days of life. So basically, in utero, the mom was doing this conjugation of unconjugated bilirubin for the fetus. But now that the fetus is delivered, now that the baby is out, the baby will now have to start doing this by him or herself. High levels of bilirubin, usually above 25 milligram, can cause deafness, cerebral palsy, or other forms of brain damage in some babies. In less common cases, jaundice may indicate the presence of another condition such as infection or a thyroid problem. Unconjugated bilirubin, as we said earlier, is not soluble with water. Conjugated bilirubin is soluble with water. So in order to excrete bilirubin, you have to convert it from the unconjugated state to a conjugated state. So that is the conversion, so that it has to be excreted as or in the form of a water soluble. Conjugated bilirubin is otherwise known as the red bilirubin, whereas unconjugated bilirubin is known as indirect bilirubin, and this indirect bilirubin is a potential toxin because it is not excretable, it is not in an excretable form. Conjugated bilirubin should break down to unconjugated bilirubin by ways of enzymes. In babies, they don't have these enzymes, and this is known as the bilirubin conjuctase. They don't have these enzymes in enough quantities in order to break down or to conjugate the unconjugated bilirubin. So what happens is that it keeps circulating, and this lowers hepatic activity along with a relatively large bilirubin load, decreases the liver's ability to conjugate bilirubin, and then it increases the susceptibility of newborn to jaundice. So this is basically what happens with this issue of conjugation of the bilirubin. So when a baby is, mom is pregnant, the baby didn't have the responsibility of conjugating or converting this yellow lipid soluble into water soluble in order to be excreted via urine. But when the baby is delivered, the baby will now have to do this. However, due to the immaturity of the baby's liver, the baby doesn't have that ability to conjugate this unconjugated bilirubin so fast. And so now it starts to circulate. It keeps circulating, and the levels can grow or can rise into a dangerous level, and that could cause a brain damage. So when a baby has a bilirubin level more than 25 milligram, that is actually considered as kernicterus. Kernicterus is an excessive level of bilirubin that can cause a baby to have a brain damage. So kernicterus is a form of brain damage as a result of excess bilirubin, and that is when the levels exceed 25 milligram, and that is very, very bad for the baby. Pathologic jaundice. There are two major types of jaundice. We have pathologic jaundice and we have physiologic jaundice. So now let's talk about the pathologic jaundice. So with this pathologic jaundice, you will see the clinical manifestations presenting within the first 24 hours of life. So within first 24 hours of delivery, you will start to see the clinical manifestations of jaundice. So we're going to cover some of the signs and symptoms, but before we get into that, we will go over some of the causes of this pathologic jaundice. And so in utero, the fetus lives in a state of relative hypoxia. So to maximize the oxygen carrying capacity of the blood, the fetus produces more red blood cells than the normal adult or child has. So now if something causes an excessive number of red blood cells to break down, such as in the case of ABO or Rh incompatibility, birth trauma, or infection, or anything impairs the baby's ability to pass bilirubin out of the GI tract, such as MPO, delayed stooling, meconium ileus, then what happens is that the bilirubin level can rise to dangerous levels, requiring treatment to prevent buildup in the brain. And when there is a buildup of bilirubin in the brain, it is called kernicterus, as I mentioned on the previous slide. And these kernicterus can cause brain damage and death. Now let's focus now on the causes of pathologic jaundice. There are three major causes of pathologic jaundice. We have the first one there is erythroblastosis fetalis. So this erythroblastosis fetalis is an isoimmune hemolytic disease. It occurs when an Rh negative mother is pregnant with Rh positive fetus and maternal antibodies cross the placenta. So maternal antibodies enter the fetal circulation, then attach to and destroy the fetal red blood cell. However, with the use of ROGAM, the incidents have dropped significantly. So if you remember when we talked about the Rh incompatibility, so that kind of goes hand in hand with this erythroblastosis fetalis. So when mom is pregnant and she gets ROGAM, the chances of that isoimmunization or alloimmunization decreases. And that is what this is talking about. And also ABO incompatibility is another cause of pathologic jaundice. So basically with ABO, and when people who have one blood type receive blood from someone with different blood type, it may cause their immune system to react. And when this happens, this is called ABO incompatibility. So this can give rise to pathologic jaundice. And of course, the last point there is Rh incompatibility. So with Rh incompatibility, this is a condition that occurs during pregnancy if a woman has Rh negative blood and her baby has Rh positive blood. So if you're Rh negative and your baby is Rh positive, your body will react to the baby's blood as a foreign substance. And so that is, what these are the major causes of this pathologic jaundice. And so with pathologic jaundice, once again, you'll see the manifestations within the first 24 hours of delivery. And so how do you know that your baby has jaundice? Well, to check jaundice, you pretty much have to blanch the skin over a bony prominence, such as the forehead, the nose, or the sternum, by pressing firmly with the thumb. After pressure is released, the area appears yellow before normal color returns. So if you see a baby that is jaundice, you will definitely see it. You can never miss it. So you'll see the yellowing of the skin, the yellowing of the sclera of the eyes. So those are signs of jaundice. And the word jaundice, jaundice is not actually the disease, but that's the manifestation of hyperbilirubinemia. So the word jaundice is actually derived from jaune, and that's a French word that means, yellow, jaundice. So that is a manifestation of hyperbilirubinemia. So when a baby's bilirubin level is high, that is called hyperbilirubinemia, and that is manifested by that jaundice. And so we just covered pathologic jaundice. The next is physiologic jaundice. And so with physiologic jaundice, the clinical manifestations are present 24 hours after delivery. So you'll start to see physiologic jaundice post 24 hours of delivery. And this physiologic jaundice occurs in 50% of term babies and about 80% of preterm newborns. So this physiologic jaundice is caused by accelerated destruction of fetal red blood cells and increased reabsorption of bilirubin by liver because of an underdeveloped liver. So the baby's their liver is immature. So due to that immaturity of the liver and the acceleration of the destruction of red blood cells and increased reabsorption by bilirubin subsequent to underdeveloped liver, That is what gives rise to this physiologic jaundice. So things such as dehydration can predispose a baby to becoming jaundiced. Cephal hematoma is also a risk factor that could cause a baby to be jaundiced. Remember when we did newborn, and I said that if mom delivered vaginally and she had a vaginal assisted vaginal delivery, or she had a vacuum assisted vaginal delivery, or even a forceps assisted vaginal delivery, that the baby who was vacuumed may have a cephal hematoma. And that cephal hematoma is the ruptured blood vessels underneath the scalp of the baby, the head of the baby. So that will cause a baby to experience, or will put a baby at risk for developing physiologic jaundice. So naturally, what will happen to this baby who had a cephal hematoma is that naturally there will be a lysis of the red blood cells. So on that crown of the baby's head, where you have that ruptured vessels, naturally it will break down, and the end product of red blood cell lysis will be what? Bilirubin. So now that will cause an overwhelming increase on the circulating bilirubin level, and we're talking about immaturity of the baby's liver. So now that causes the bilirubin level to rise significantly, thereby predisposing this baby to getting jaundice. Infection is also another risk factor, another reason why a baby could have a physiologic jaundice. So physiological jaundice occurs in most newborn, and that is totally normal. Sometimes we call it the breastfeeding jaundice. This mild jaundice is due to the immaturity of the baby's liver, as I mentioned, and then that leads to a slow processing of a bilirubin. It generally appears at 2 to 4 days of age and disappears by week 1 to 2 of age. And you know how I like to describe this physiologic jaundice? So when a baby is, we said that in utero, the mom is doing the conjugation of the unconjugated bilirubin for the baby. And now the baby is delivered. The baby have to do it by him or herself. So I always like to liken this to a brand new nurse. So imagine, think about yourself. You're a brand new nurse, first day on the unit. You are working, or first day after you have been let go, or by your preceptor, you've been set free. So your preceptor have signed you off and say, hey, we have a nurse who can work on her own or his own. Now you are working on your own for the first time. So now, will I expect you to work at the same pace as a nurse who have been on the unit for 5 to 10 years? No. You're going to work at a slower pace because you're brand new. You're trying to get used to it. You're trying to get all your work done, but the pace is slow. The nurse who have been on the unit for a longer time, a seasoned nurse, experienced nurse, will go faster because this is what they do. They know it. They're used to this. It's nothing for them. So now, if you think about that, that can help you to understand what happens, that when a baby is delivered, that the baby is still immature, still inexperienced, the liver is still immature. Due to that immaturity of the liver, they cannot handle that load of doing that conversion of that, bilirubin from being the lipid soluble into a water soluble. So if they're not able to do it, it will start to build up. So now what you're going to see is a yellowing of the skin, the sclera, and other tissues of a newborn infant. So now your baby has jaundice. What will you do? Well, you have to feed the baby. So feeding the baby is one of the interventions, because if it is caused as a result of dehydration, the baby is not getting enough, especially in babies who are breastfed. If mom doesn't have enough breast milk, you may give formula to the baby, you may feed the baby. So feeding the baby is good. If the baby's level is really high, we have to start the baby on what is called phototherapy. The phototherapy is basically the exposure of the newborn to high intensity light. The light exposure will decrease serum bilirubin levels in the skin by facilitating biliary excretion of unconjugated bilirubin. So that is basically what the phototherapy does. I remember when I was a kid, when I was younger, back in Africa, and my mom used to when she has babies, I'm the first in her among the family of 6. I have 5 siblings. So my mom, what she used to do is, if she has a baby and the baby has jaundice, she will bring me out, and I will sit outside by the corridor, or the well, here you will call it what will you call it, whatever. I will be outside, we call it a corridor, so, or the balcony. So now I will be at the balcony, and then my mom will bring out the baby, and this is usually like in the morning when the sun starts to rise, that early morning sun. So my mom will put the baby in a bassinet, and I will sit down there in the balcony watching the baby. So I didn't know that my mom was doing a freaking phototherapy. So she was allowing the sun to help my sibling, my baby brother or my baby sister who had a jaundice. So that's what she was doing then. But that is actually the concept of phototherapy. So that exposure of the baby to the light helps to break down the bilirubin. So the phototherapy, once again, is the exposure of the newborn to high intensity light. So here we use the UV light. That UV light will now facilitate the biliary excretion of the unconjugated bilirubin. So now when your baby is under the phototherapy, there are certain things you need to do as a nurse. A baby that is under bilirubin, under the light or phototherapy, you need to make sure that the eye is covered. So eye patch, the baby needs to wear, the eye has to be covered with a patch because of the UV light. You have to make sure that the baby, that the diaper is put on the baby. You don't want to expose the baby's genital area. The baby's organ needs to be covered because of the UV light. Also, make sure you check the temperature of that, the isolate. Make sure that you check that it's not too hot for the baby. Of course, feeding needs to be maintained. If the baby is a breastfeeder, whenever it's time for the baby to feed, you bring the baby out and let the baby feed. If the baby is a breastfeeder, mom also have to be, there to feed the baby. And so because of the feeding, we do what is called cluster care. So cluster care means that if I bring the baby out for feeding, that I have to make sure I do everything on that baby before I put the baby back in. So that way you minimize the bringing out of baby for diaper, for feeding, and for whatever. So you bring the baby out, you feed, you make sure the diaper is changed, baby is comfortable before you put the baby back inside the isolate or the phototherapy light, because you want to make sure that the essence of doing the phototherapy that is successful, you don't want to disrupt or interrupt the phototherapy. So you always remember that. And of course, there is another intervention called exchange transfusion. And this exchange transfusion is only done in extreme cases. And so with this exchange transfusion is basically the withdrawing and replacement of the newborn's blood with donor blood. So the newborn's blood will be withdrawn and replaced by a donor blood. So that's basically what happens in an exchange transfusion. And this is usually done under rare cases or extreme cases. Impaired conjugation of bilirubin. A newborn does not take in calories when this is happening. When there is impaired conjugation of bilirubin, it happens because the newborn is not taking in calories, taking in enough calories, or maybe mom may be breastfeeding, but it's not enough. The baby is not getting enough. And also it can happen due to defect in bilirubin excretion because of decreased GI motility, decreased oxygen to the liver. And this is also physiological jaundice. So under this case, you have to make sure that the infant is fed. So the infant needs to be to feed in order to establish flora in the intestines and in order to pass meconium, which is high in bilirubin. Meconium is high in bilirubin. If a baby is delivered, the baby within the first 24 hours should pass meconium. A baby that has not passed meconium within the first 24 hours is at risk for developing jaundice. And also when feeding is delayed or poor, or the feeding is poor, the bilirubin will increase. So these are some of the attributing factors to this physiological jaundice or impaired conjugation of bilirubin. Now we have this breastfeeding jaundice. This breastfeeding jaundice basically means that jaundice can occur when a breastfeeding baby is not getting enough breast milk. due to difficulty with breastfeeding, or because the milk or the mom's milk isn't in yet. And this is not caused by a problem with the breast milk itself, but rather the baby is not getting enough to drink and become dehydrated. So the breastfeeding jaundice will be seen as a result of dehydration. And so it may be necessary to interrupt breastfeeding for a short period when bilirubin reaches 20 milligram per deciliter. So that has to be, you may have to stop the breastfeeding at that point and give formula feeding, so that you want to hydrate the baby and make sure that the baby is getting enough milk. If not, we don't want this level to continue to rise to that dangerous level known as kenic terrors, when the baby can suffer brain damage. Now let's consider the gastrointestinal adaptation, so digestion and absorption. By 36 to 38 weeks, the GI system is adequately matured with enough or with enzymatic activity and the ability to transport nutrients. So the full-term newborn has enough intestinal and pancreatic enzymes to digest simple carbohydrates, proteins, and fats. Lactose is the primary carbohydrate in the breastfeeding newborn and is generally easily digested and well absorbed. So lactose is the primary carb in the breastfeeding newborn, and it is generally easily digested and well absorbed. Newborn cannot digest starch. So this is the reason why we wait until the first few months of life before we start introducing other starch to newborns. We usually wait until about 4 to 6 months before we start introducing starch to these babies, because they cannot digest starch easily. By birth, newborn has experienced swallowing, gastric emptying, and propulsion. And so what is gastric emptying? This gastric emptying was a process by which the food leaves the stomach and enters the duodenum. On the other hand, propulsion is the movement of food along the digestive tract. The major means of propulsion is peristalsis, and this is a series of alternating contractions and relaxations of smooth muscle that lines the walls of the digestive organs and forces food to move forward. And you remember this, I think you covered that in pathophysiology, so that is just a review. Now let's look at elimination. Meconium is the earliest stools of a mammalian infant. So we're all mammals, right? So meconium is the earliest stool. That is the very first stool that the baby passes. Meconium is formed in utero from the amniotic fluid, and its constituents include intestinal secretions, shed mucosal walls, bile, and water. So newborn passes meconium within 24 to 48 hours of life. The first 24 hours, most babies will pass meconium. Now, if a baby doesn't pass meconium within the first 24 hours of life, we give them up until the next half, which is 48 hours. Hopefully, they should pass meconium. If a baby has not passed meconium within this period, then it is a concern. So this newborn, they pass meconium within 48 hours. The frequency of bowel movement varies, and we'll talk more about that. So when a baby is delivered on day 1, if you look at the picture, so the first one there is a picture of a meconium, the one that is tarry in color. So that is meconium. Meconium is thick, tarry, black colored. The second one is a baby who is being breastfed. So the breastfeeder, this is how their stool will look like. It's a breast milk. It's usually yellow, gold, soft, musky or mushy color. So it is a yellow, gold, soft, mushy stool. That's actually how it is described, and that is your breastfed baby's stool. Then the last picture, the last stool on the picture is a formula. So when a baby is fed formula, that's how the stool look like. It's cow's milk formula, and it's usually pale yellow, formed and pasty. So that's how, that's the variations between the the stools of these newborns. So on day 1, the baby is expected to have one bowel movement, and that's usually that meconium. Day 2, the baby is expected to have 2 bowel movements. So you see that it goes up according to the day of life until it gets to about day 5. So day 3, the baby should have 3 bowel movements. Day 4 bowel movements. Then about day 5, it should now regulate. So that is usually what, how this happens. And meconium, unlike the later feces, is viscous and sticky like tar, as I mentioned earlier. Its color is usually a very dark olive green and is almost odorless. So that's what meconium look like. And if you look at this picture, this is why when a woman breaks her water, if her amniotic fluid is, if the baby passes meconium in utero, the color will be greenish in color or yellowish in color. So that is because of this amniotic fluid. That is because of the meconium. If a baby passes it in utero, which is usually a sign of distress, it will come out, the color of the fluid will be greenish or yellowish in color as, mom goes through labor. And so that is the elimination adaptation with your newborn. Don't forget that. Please remember it, that a baby who has not passed meconium is also at risk for developing jaundice. Now let's go to newborn urinary adaptations. So this is the urinary adaptations, the newborn kidney, difficulty in maintaining fluid and electrolyte balance. These are the characteristics that you will see if there is a difficulty in maintaining fluid and electrolyte balance. There will be decreased rate of glomerular flow and limited secretions of solids. There will be limited tubular reabsorption, and of course there will be limited ability to concentrate urine. So the newborn's kidney function is immature compared with that of an adult. The glomerular filtration rate doubles during the first weeks of life, but does not reach adult levels until the age of 1 to 2. And this is due to the physiologic inefficiency of the newborn's kidney. So the newborn's kidney is unable to dispose of water rapidly when necessary because the kidney favors reabsorption of sodium. The newborn is also unable to adapt to large changes in volume of body fluids because the kidneys are so immature and can result in fluid overload. And so this usually happens with IV fluids. So this is why when we're giving a baby an IV fluid, we are very, very careful in doing so because we don't want to give the baby a fluid overload. And the normal output is usually 2 to 5 cc's per kilo per hour. Now, a newborn who has not voided by 48 hours should be assessed for adequacy of fluid intake, bladder distension, restlessness, and symptoms of pain. And of course, you want to notify the doctor if a baby has not voided by 48 hours. I'll repeat, a newborn who has not voided by 48 hours should be assessed for adequacy of fluid intake, bladder distension, restlessness, symptoms of pain, and you must notify the doctor if this is the case. The first void. Usually the first void occurs within 12 to 24 hours post-delivery. Sometimes the babies will pee as they are being delivered. So if newborn does not void within 48 hours, like I mentioned in the previous, I think I went ahead of myself here, you need to assess adequacy of fluid intake, bladder distension, restlessness, and symptoms of pain. And of course, you want to notify the MD. The absence of kidneys or abnormalities are usually discovered before birth because there is a lack of urine excretion, which causes what is known as oligohydramnios or low amniotic fluid. So when a mom has oligohydramnios, which means that the fluid around the baby is less than 5 cm, that patient needs to be worked up. And usually when we do ultrasound, they will see that if a baby has absence of kidneys or there are some renal anomalies that is predisposing this woman to experiencing oligohydramnios, the baby will now have to, once the baby is delivered, more workup will be done on the baby in order to see what is actually going on with that baby. Immunologic adaptation. The newborn's immune system. Well, the newborn immune system isn't fully activated until after some time following birth. And so the white blood cell responds slowly and inefficiently when the body becomes infected. Also, the newborn has poor hypothalamic response to pyrogens. And so this is the reason why fever in newborn is not a reliable indicator of infection. Hypothermia is more reliable indicator of infection. So a fever is not a reliable indicator of infection in newborn period. Rather, it is hypothermia that is a reliable indicator of infection. And this is because newborn has poor hypothalamic response to pyrogens. And when a baby is delivered, this is the reason why we do the skin to skin, because they don't have that ability to control their temperature. The hypothalamus hasn't really effectively kicked in within that first day of life. So that is why we swaddle the baby, we put the baby skin to skin, we put a hat over a baby's head, trying to conserve the body heat, knowing that if a baby becomes cold or experiences hypothermia, that is can be very fatal to the baby. So once again, fever is not a reliable indicator of infection in newborn period, rather hypothermia, and that is a drop in the temperature. That is more reliable indicator of infection. Passive immunity from the mother. Maternal immunoglobulin G, or maternal IgG, which crosses the placenta, is transferred to the fetus during the third trimester. And so this passive immunity usually lasts for 4 weeks of pregnancy, and passive acquired immunity occurs during the third trimester, as I just said earlier. Now, the preterm infant may be more susceptible to infection, and the reason why this is the case is because these preterm infants were not, they were born prior to the third trimester. So if they were delivered before the third trimester, they didn't get the benefit of getting that maternal immunoglobulin G. However, the mom or the mother will continue to provide passive immunity to the infant via breast milk. So this is one of the reasons why we encourage breastfeeding, because breastfeeding helps to give that passive immunity to the infant. Colostrum, which is the forerunner of breast milk, is very high in the secretory form of immunoglobulin A, or IgA. So newborns start to produce this IgA in the intestinal mucosa at 4 weeks of 4 weeks of age, or 4 weeks after birth. And this is an important immunoglobulin that does not cross the placenta. This IgA protects the respiratory and GI systems. The breastfed infant will receive some protection from the mother's breast milk. So the importance or the benefits of breastfeeding is very, very great. So we always encourage moms to breastfeed, and we teach them, or we let them know the values or the benefits of breastfeeding. The first period of reactivity. This first period of reactivity starts at birth, lasting 1 to 2 hours. During this period, the newborn is awake and active, and this is usually the best time to initiate feeding and bonding. The newborn also appears hungry and has a strong reflex. Natural opportunity to start breastfeeding. So we do skin to skin. We put the baby on mom's skin and abdomen, and then as the baby stays there, most times you might even see the baby crawling or moving closer to the breast. So that becomes a natural opportunity to start breastfeeding. During this period of first period of reactivity, the vital signs are elevated. The baby's respirations may be rapid. You may hear crackles, retractions, and mucus secretions because remember, the baby came out from a fluid-filled environment. So crackles will be present because of the fact that the baby was just delivered. Bowel sounds are usually absent. Then comes a period of inactivity to sleep phase, and then the newborn's activity gradually decreases during this period. Heart rate and respiration decrease as newborn enters the sleep phase. It will be difficult to awaken, and the baby will show no interest in sucking. So, of course, who wants to feed when they are sleeping? So when the baby is in that period, forget it. Bowel sounds now becomes audible during this period. The second period of reactivity. Well, during the second period of reactivity, the newborn again is awake and alert. And this period of reactivity lasts 4 to 6 hours in normal newborn. Heart rate or the heart and respiratory rates increase. The nurse also needs to be alert for apneic periods, which may cause a drop in the heart rate. So now it is not uncommon for you to notice a transient apnea in a newborn. So that is momentarily. So the baby, as you're doing your assessment on the newborn, and you notice that the respiratory rate, that there is a pausing in it. If there is a pausing with regards to the respiratory rate, that is totally fine. It's an apneic period, as long as it doesn't exceed 20 seconds. You could have that apnea less than 20 seconds, that is totally fine. But if it lasts or lingers more than 20 seconds, definitely you have to get a doctor, because the baby is showing you signs of respiratory distress. During the second period of reactivity, the baby or the newborn passes meconium. The newborn sucks, roots, and swallows, and these are all cues of hunger. And all is done in the second period of reactivity. Newborn senses. So now let's wrap up this lecture with the newborn senses. So just like you and I, we have all the 5 senses as human beings. Our babies have the same. They have visual, auditory, olfactory, taste, tactile, all of them, they have it. So the newborn is able to, is alert and able to follow and fixate on complex visual stimuli for short periods of time. They also, newborn can process and respond to visual and auditory stimulation. So if you say something to a baby, the newborns, they know who their fathers are, right? Especially if you're a father or a mom who is used to talking to your baby, and when they were in utero, you sing to them, you talk to them. When the baby comes out, if you're singing the same music, they will react to, they will respond to it, because you could see the baby turning the neck, looking towards that direction, because they recognize that. So they can process and respond to visual and auditory stimulation. They also experience habituation, olfactory, taste, suckling, all those things the newborn would do. With regards to tactile, they are able to select people by smell. The baby can smell when the mom is in the room. When the mom is in the room, the baby knows it, especially babies who are breastfed. They will smell the mom. They know that the mom is in the room, or if the mom is not in the room, they could tell that she is not there. And by the way, the habituation refers to a decrease in response to a stimulus after repeated presentations. So that is what that term habituation refers to. The baby also is able to respond selectively to different tastes. What do we mean by that? When you give a baby who is a breastfeeder, you give formula to them. These babies are smart, right? The baby will know that this is not a breast milk. Breast milk, by the way, is very sweet. So the baby knows the difference between breast milk and formula. If it's a smart baby, some babies will push your hand away if you're giving them formula, because they don't want it. After drinking, the breast milk, they don't want to take a formula. So they know that. They're also sensitive to being touched and cuddled and held. So when you hold a baby, they feel love. They know that they can trust their caregiver. And that is all because their newborn senses are all intact. And finally, the newborn is able to attend to and interact with environment. All these things we see in the newborn as the baby is making that transition or adapting to life in the extrauterine, adapting to the extrauterine life. And you see all this. And so this is the end of this newborn adaptation lecture. And I'm going to go over the newborn assessment, but that will be coming up in the next presentation. So this is the end of that. Please remember all the things that we covered in this, all the things that I went over. We talked about the newborn, the respiratory adaptations of the newborn, causes of respirations, or cardiovascular adaptations. Remember all those things. And for the foramen ovale, we talked about that, and the PDA. By the way, I forgot to mention that if the PDA fails to close, so when a baby has a PDA, and we said that the PDA usually will close within 15 hours of life, right? But the permanent closure will happen in 3 weeks. So you have a baby who has a PDA failed to close. Usually what we do is we give IV indomethacin to encourage the PDA to close. We give IV indomethacin to enhance the PDA to close, or to encourage it to close. We also give IV ibuprofen. So IV ibuprofen is given to encourage the PDA to close, or we give IV indomethacin. So indomethacin or ibuprofen is given to encourage the PDA to close if it fails to close. Remember, we said that if it fails to close, that it means it's an indication that the newborn is poorly perfused. So we have to encourage the PDA to close by giving that IV indomethacin or IV ibuprofen. Now, if that fails, the newborn will have to go for a surgery to correct or to close the ductus arteriosus. We also talked about the thermal and sensory stimuli, thermoregulation, methods of heat loss. Please remember those things, and the conjugation of the bilirubin, we covered that. Pathologic and physiologic jaundice, know the differences between the two of them, as well as the intervention. And that's pretty much it. This is the end. See you.